Over a period of 24 hours, this 77-year-old lady developed complete blindness on her right eye and furthermore a ophthalmoplegia. Unfortunately, it took her several days until she was taken from her rural community into the hospital. There on the CT scan, a normal anterior ethmoid was seen with the accidental finding of large conchobulosas bilaterally, but the posterior ethmoid showed a soft tissue mass apparently thinning the bone towards the skull base and compressing the area of the optic nerve, especially in the posterior ethmoid and the sphenoid sinus. The nerve seemed compressed but not invaded. So with the clinical diagnosis of a mucocele of the posterior ethmoid and the sphenoid sinuses, she was taken to the theater and prepared for endoscopic revision under local anesthesia. To create access to the posterior ethmoid, the lateral lamella of the conchobulosa on the right side had to be resected. Therefore, a local anesthetic was injected under the mucosa, and after a short while the lateral lamella of the turbinate resected. Here, with a pair of scissors, the concha is opened and the lateral lamella grasped. Clearly, one can see how this lateral lamella bulged into the lateral nasal wall. Step by step, this portion now is resected and view becomes free into the lumen of the conchobulosa with polypoid tissue protruding from the anterior face of the ethmoidal bulla. So in this case, the conchobulosa was pneumatized from the middle meatus. Now view becomes free onto the anterior face of the ethmoidal bulla and the hiatus semilunaris. The anterior wall of the bulla is carefully pressed in, and diseased mucosa, which is polypoidally changed, removed from out of the lateral sinus above and behind the bulla. There is little bleeding with the procedure. After the bulla had been resected and the ground lamella carefully perforated, a pulsating and fluctuating mass can be palpated and finally opened. The contents of the mucocele drain. It contained almost 10 milliliters of a moderately viscous mucopus. With the aspirator, these contents are removed to reveal a wax-like concretion at the floor of this mucocele cavity, which first made us think of a mycotic infection. There was, however, no histological or cultural evidence of such an infection. So with a curved aspirator, these wax-like concretions, which probably resulted from thickened debris and secretion, were removed via the perforation of the ground lamella. The cavity of the mucocele had a diameter of almost 3.5 centimeters. In that cavity, one clearly can see now the cause of the optic nerve from 9 o'clock to the center of the picture. It protruded from out of the lateral wall. At 9 o'clock there was a small granulation tissue, apparently corresponding to the area where the lesion to the optic nerve occurred. Once again, a view in the mucocele cavity with the optic nerve and the granulation tissue at 9 o'clock. No packing was used. A fortnight later, the ophthalmoplegia had resolved completely. Vision, however, was not restored again, as the ophthalmologist already had described an atrophy of the optic nerve when surgery was performed. On a follow-up 6 weeks after the procedure, the mucosa in the sphenoid sinus completely had normalized, and we see normal mucosa covering the optic nerve. At that time, the patient felt that she could differentiate between dark and light again, but the vision was not restored. The next patient presented with a classical mucocele of the maxillary sinus, which followed a Caldwell-Lick procedure 33 years ago. When performing diagnostic endoscopy in the inferior meatus, the surgical window was completely scarred down with only a small recess to be palpated. There was no connection into the maxillary sinus. During the Valsalva maneuver, clearly the movements of the mucocele contents from the maxillary sinus could be seen. When the middle meatus was approached, a large bulla could be seen filling almost the entire middle meatus. Here too there was no connection into the maxillary sinus, so the natural ostium had closed down completely. In preparation for surgery, a local anesthetic was injected under the mucosa of the uncinate process in a typical way, and the uncinate process then resected. When the blade was turned upwards and the inferior parts of the uncinate removed, polypoidally changed mucosa was found to fill the ethmoidal infundibulum. Then the anterior wall of the ethmoidal bulla was taken down to give a wide access towards the lateral nasal wall. View into the bulla reveals that this was not diseased itself. Then the natural ostium was palpated with a bent spoon, and with the upbiting forceps the scar tissue removed. When penetrating, purulent secretion from the mucocele drained into the middle meatus. The area of the natural ostium then was enlarged with the backbiting forceps, removing the scar tissue and the inflamed mucosa from that area. With the curved aspirator, the secretion was removed from out of the maxillary sinus, and mucosal fragments from the posterior surrounding of the ostium removed. Finally, a clear view through a wide access resulted into the maxillary sinus, whose mucosa was not touched. Within 3 weeks, the mucosa of the sinus and the ethmoid cavity had completely normalized. This patient had experienced a Caldwell-Lick approach to her right maxillary sinus 27 years ago. she presented with orbital protrusion of her right eye and considerable pain and pressure feeling of her cheek. Tomography revealed a soft tissue mass in the sinus with the lateral portion extending not only through the floor of the orbit but back into the retromandibular fossa. Nasal endoscopy revealed a complete closure of the natural maxillary sinus ostium, which was embedded in scar tissue as well. Here we see the protrusion of a mucous membrane. So in the typical fashion, the uncinate process is first injected, and we can see pus drain in a few moments from the second injection point already. So this apparently was under high pressure in the maxillary sinus and the infundibulum. With the aspirator, the injection points are compressed to avoid further bleeding, and then the uncinate is resected. Here too, with the first incision, masses of pus protrude. These are aspirated and the uncinate process then resected in the typical fashion. With the spoon, the area of the natural ostium now is palpated, and this enlarged at the expense of the anterior nasal fontanelle. The reverse cutting forceps is an ideal instrument for that. With the bend aspirator, the pus was evacuated and the natural ostium widened. View becomes free now into the mucocele cavity. Here the view with the 70-degree lens, but we see the bulging of another mucocele at the posterolateral wall of this mucocele. Attempts to open this via the newly created opening in the middle meatus fail. During the Valsalva maneuver and when moving the jaw, clearly the movements of this mucocele wall can be seen. So via the canine fossa, the maxillary sinus was approached, and here we see the bent spoon through the middle meatus entering the maxillary sinus through the widened natural ostium. Now with the trocar sleeve, the anterior wall of the second mucocele, respectively the second chamber of the mucocele, is opened, and we look into a larger cavity than the first one. Its contents are aspirated, and through the trocar sleeve with the biopsy forceps, the anterior wall carefully taken down. Care is taken not to put a lesion to the orbital floor, as there the bone already is missing. Step by step, the anterior wall of that second mucocele chamber are taken down until a wide communication results. This fragment adheres to the floor of the orbit, which is carefully palpated. The peri-orbit is still intact, so no packing was used in this case too. There was a normal post-operative course. The protrusion of the eyeball was gone immediately after the surgery, and the patient dismissed the following day. This again is the view out of the widened ostium into the middle meatus. Here we are dealing with a patient with a mucocele of the anterior ethmoid. The roof of the ethmoid has been eroded, as has the border to the orbit. The frontal sinus was clear, as was the posterior ethmoid. During diagnostic endoscopy, a paradoxically bent middle turbinate was found with polyps rising from the contact area between the turbinate and the septum. These were not touched as first. The uncinate process was resected in a typical fashion. Care was taken not to create a lesion to the lateral aspect of the middle turbinate. There was edematous mucosa in the infundibulum, and here we have a look at the huge bulla, which is in intense contact with the turbinate too. After this was resected, a more or less horizontal structure was seen, which was assumed to be the floor of the mucocele. When the bone was removed from that area, however, it soon became clear that this was orbital fat protruding now, which apparently, due to the pressure from the mucocele above, has been pushed very far medially. This situation now renders the further procedure more difficult, as one has to bypass this small prolapse of orbital fat. So working further up, we now can identify at 11 o'clock the way into the frontal sinus, and lateral to it at 12 o'clock towards the center of the picture, the bottom of the mucocele. We are dealing with very narrow conditions, and it's difficult to have the scope plus the instrument there at the same time. However, one succeeds in opening the mucocele, and masses of a moderately viscous secretion protrude and can be aspirated. Finally, this perforation can be enlarged into an opening of approximately 8 times 12 millimeters, and a clear view into the mucocele cavity can be achieved. A Marocell sponge then was inserted to keep the orbital fat from protruding further. It was soaked with a cordysporin solution, and finally the polyp that originated from the middle turbinate at the contact area to the septum is resected. Here too a Marocell is inserted to prevent adhesions there. Both Marocell sponges were removed 2 days after surgery, and there were no complications encountered. There are limitations to the endoscopic approach for mucoceles. Like in this 17-year-old boy with a mucocele who was suffering from cystic fibrosis. Despite the fact that endoscopically, under local anesthesia, the mucocele could well be identified and opened through the frontal recess, and the thick glue-like secretion removed with the aspirator, an external approach had to be used in the end. Here in the frontal recess, the frontal sinus ostium was enlarged, and when applying pressure to the upper eyelid, masses of a highly viscous secretion protrude. However, these secretions prove too viscous to be aspirated. The masses didn't drain by themselves, and even when an aspirator was inserted and irrigations were performed, the masses could not be removed. There was no chance to reach that far laterally with an instrument through the frontal sinus ostium to remove the thick inspissated material. So finally, the endoscopic approach had to be abandoned, and an external approach under general anesthesia was performed. At the end of the external surgery, the Mucoceles sponge was replaced by a polyethylene drain which remained for 3 months.